Acute kidney injury, AKI, previously known as acute renal failure, is a sudden episode of kidney failure or kidney damage that happens within a few hours or days. It causes waste products to build up in the blood, making it hard for the kidneys to maintain the right balance of fluid in the body. AKI can affect anyone, but is more common in people who are already hospitalized, particularly in those who need intensive care. Causes. AKI can be caused by a variety of factors which can be categorized as pre-renal, due to insufficient blood flow to the kidneys, often from dehydration, blood loss, or shock. Intrinsic, damage to the kidney tissue itself, which can be due to ischemia, toxins, infections, or inflammation. Post-renal, obstruction of urine flow due to conditions like kidney stones, tumors, or an enlarged prostate. Symptoms: decreased urine output, although occasionally urine output remains normal, fluid retention, causing swelling in the legs, ankles, or feet, shortness of breath, fatigue, confusion, nausea, weakness, irregular heartbeat. Diagnosis: AKI is diagnosed based on serum creatinine, increase in serum creatinine by 0.3 milligrams B within 48 hours, or an increase to 1.5 times baseline, which is known or presumed to have occurred within the prior 7 days, or urine volume 0.5 milli per kilogram for 6 hours. Urinalysis for detecting abnormalities indicating kidney dysfunction. Urine output, monitoring for oliguria, low urine output. Imaging tests, such as ultrasound to assess the size and structure of the kidneys and check for blockages. Kidney biopsy, in certain cases, to determine the specific cause of the intrinsic AKI. Treatment: management of AKI involves treating the underlying cause and supporting the kidneys while they heal. Pre-renal AKI. Treatment focuses on correcting the cause of decreased blood flow, such as administering fluids or blood products. Intrinsic AKI may require more complex interventions, including medications to control the cause of the kidney injury, and in some cases, dialysis. Post-renal AKI, relieving the obstruction causing urine to back up into the kidneys, possibly requiring catheterization or surgery. Prognosis. The prognosis of AKI depends on the patient's overall health, the severity of kidney dysfunction, and the underlying cause. Early detection and prompt treatment can lead to complete recovery, though some may experience permanent kidney damage or increased risk for chronic kidney disease. High yield points. AKI is characterized by a rapid decline in renal function, leading to the accumulation of waste products and fluid imbalance. Causes of AKI are categorized as pre-renal, intrinsic, and post-renal. Diagnosis involves serum creatinine, urinalysis, and often imaging studies. Treatment targets the underlying cause and supports kidney function, potentially requiring dialysis in severe cases. Early intervention is crucial for recovery, and the prognosis varies based on the cause and severity of the injury. Clinical case: acute kidney injury, AKI. Patient information: age, 58-year-old male, occupation, office worker. Medical history: hypertension managed with medication, type 2 diabetes. Presenting complaint: the patient presents to the emergency department with complaints of decreased urine output, lethargy, and swelling in his legs over the past few days. History of present illness: the patient reports that he has been feeling increasingly tired and noticed that his shoes were tighter than usual due to swelling in his feet and ankles. He also mentions that he has been urinating much less than normal, despite drinking the same amount of fluids. Physical examination: general, mildly distressed due to discomfort from swelling. Vital signs: blood pressure 160s 95 milliliters, heart rate 88 BPM, mild tachypnea. Cardiovascular: mild jugular venous distension, no murmurs, pedal edema. Respiratory: clear lung fields. Abdominal: sunder, no organomegaly. Extremities: bilateral lower limb pitting edema, diagnostic workup. Serum creatinine elevated at 3.2 milligrams per milliliter. Blood urea nitrogen elevated. Urinalysis: proteinuria and microscopic hematuria. Urine output monitoring confirms oliguria, 400 milliliters urine 24 hours. Renal ultrasound shows normal-sized kidneys with no signs of obstruction. Assessment: A 58-year-old male with a history of hypertension and diabetes presents with decreased urine output, lethargy, and lower limb edema. Laboratory findings indicate a significant rise in serum creatinine from baseline, consistent with acute kidney injury, AKI. Management plan. 1. Fluid management. Cautious administration of fluids to avoid volume overload, considering oliguria and edema. 2. Medication review and adjustment, temporarily discontinuing potential nephrotoxic agents, including certain antihypertensives. 3. Hemodynamic monitoring, to ensure adequate blood pressure control without compromising renal perfusion. 4. Diabetic management, tight glycemic control using insulin to avoid further renal insult. 5. Renal consultation, for further evaluation and management, including the consideration of temporary renal replacement therapy if the condition does not improve. 6. Investigation for underlying cause. Further testing to determine the specific cause of AKI, such as diabetic nephropathy, hypertensive nephrosclerosis, or acute tubular necrosis. Outcome. The patient's renal function stabilizes with conservative management and careful fluid and medication adjustment. Serum creatinine levels gradually decrease, and urine output improves over the following week. The patient is educated about avoiding nephrotoxic substances and the importance of regular renal function monitoring. Half discussion points. The importance of recognizing the signs and symptoms of AKI early to prevent further renal damage. The role of careful fluid and medication management in patients with AKI to avoid exacerbating the condition. The need for a thorough investigation to identify the underlying cause of AKI for targeted treatment. The potential reversibility of AKI with prompt and appropriate management, highlighting the importance of follow-up to monitor renal recovery and adjust treatment as needed.